My name is Rafiq, and I have the pleasure of hosting you to this ongoing APPNA Merit webinar series related to COVID-19 and how we can help with a special focus on Pakistan. Today, I have the pleasure of introducing Dr. Rozina Badal Munir, who is not only one of our panel of esteemed panelists, but will also be speaking with us for the first half of the hour about COVID-19 lung ultrasound. Dr. Munir, please go ahead.
Assalamu alaikum, everyone. Today I'm going to talk about the COVID-19 lung ultrasound, and we are going to talk about the scanning techniques and a little bit about the ultrasound also. So let's start our talk. Okay, so for the ultrasound machines, आप लोगों ने देखी होंगी market में there are a lot of machines available. Mostly commonly used in the hospitals are these type of cart machines, cart-based machines, then the portable machines, and now with the availability of the handheld devices, the bedside exams have become more common and more easy for the physicians who are practicing the point of care ultrasound. So when you look at your machine, like this is the picture of a card-based machine which has a lot of knobs on it, so one gets very scared. But for the bedside or for the point of care ultrasound, I would just say there are only a few knobs which you need to know that where they are and their functions. So the first knob which you need to know about your machine, अब आपको इसको देखते ही एकदम आपको डर जाता है पर्सन कि ओके ये तो ढेर सारी नॉब, हाउ आई विल नो द फंक्शन ऑफ दिस. तो चंद एक नॉब्स हैं जिसको आपको इंपॉर्टेंटली याद रखना होता है. नंबर वन इज दैट आप यू शुड नो दैट हाउ टू टेक द इमेज, हाउ टू फ्रीज योर इमेज. अच्छा, ये क्यों इंपॉर्टेंट होती है? बिकॉज यू टेक द मेजरमेंट ऑन दैट ऑन योर इमेज. दूसरी नॉब इंपॉर्टेंट है रिकॉर्डिंग. तो लाइक जो आप रिकॉर्ड करें, you have to record it so that you can review the video afterwards. Third knob जो है वो measurement की है, and then is the another knob which on some of the machines is written as B means the brightness mode, and then it is also written as gain. So either gain and brightness mode, it is the same knob. And a third and another knob is the depth. So depth or gain को हम अभी explain करते हैं. So these 3-4 knobs you should know about your machine, and of course the turn on and turn off knob also. Okay, now let's see over here the importance of the depth knob. So if you look at over here in this image, this is also a lung ultrasound image, and you see.
Sorry, Dr. Rozina, there is problem with audio. I think.
Audio में फिर problem है?
जी थोड़ी सी वो क्रैक कर रही है.
अच्छा, आप मुझे बताएं अभी ठीक है?
जी अभी कुछ बेहतर है. थैंक यू.
अगर प्रॉब्लम हो तो मुझे बताएं, मैं फिर यहाँ से एडजस्ट कर लेती हूँ. ठीक है ना?
जी अभी तो ठीक है.
ठीक है. Okay. So the very first, so the another knob which I talked about is the depth knob. So if you look at this image, this is the image of the lung ultrasound. Now look at over here, the depth is 10 centimeters. So now you can see very nicely the complete image, like we have a bigger view of the lung. But if you look at over here, the closer view is a little bit hard to see, or not hard to see, but if you want to evaluate the closer appearance and closer anatomy, so you decrease your depth. Okay, so playing with your depth knob is just like if you want to see the more bigger view or you want to see some specific area. So look at over here, this part is now by decreasing the depth, now we are at 4 centimeters. And look at over here, now we can see this anatomy over here very nicely and more clearly. So this is the function of the depth knob. So always play with when you are scanning, always play with your depth, make it adjust it at a proper depth so that you can see the underlying anatomy. Okay. Now we come to the gain. Now the gain is also very important. So look at over here on this image, the gain is very low. So the entire image is very dark. And then on this side, the gain is very, very high. It is very hard for you to identify any of these structures. But over here, this is the appropriate gain. appropriate gain. So now you can see that this is the bright area. After I will explain you in the further slides that what it is. So now you can identify the anatomy over here. So selection of the proper gain and the proper depth is something which which is important for making the appropriate and good image, so that you can see the anatomy and so you can interpret that underlying disease. Now we come another thing which is important for you to understand and to know about is the probe selection. Now in the market there are a lot of probes, but I'm talking only about those probes which are required for the lung ultrasound. So this is the, let me tell you the part. So this is the ultrasound probe, you must have seen that one. So on the top of this probe, this part is called the footprint. Now, on the footprint, if you see over here, this is the footprint, this is the footprint. And on the footprint, you will see a little rubber padding insulation, rubber insulation. Now, below this, there are a lot of crystals. There are thousands of crystals under this padding. And these crystals are the ones which are responsible for making the images, and they have a piezoelectric effect. I'm not going into the detail of that. So the probe which has a curved footprint, these are called the curved or curvilinear probes. And there is always a frequency written on the probe. So for example, over here it's curved 6 to 2. So this is the highest frequency is 6, and it can be brought down to the frequency of 2. Then another thing on the probes is there is always a marker on the side of the, on one side of the probe. So you should know about what is the frequency and where is the marker or indicator on your probe. Now this is another type of probe, which is called the sector probe or phased array probe. So this is, look at over here, it has a rectangular footprint, and this is frequencies written over here. And this is a third type of probe. So these all are the probes which you can use when scanning the lung. So this type of probe, which has a very thin footprint and rectangular, this is called the linear. And if you look at over here, the frequency is 12 to 4. Now remember one thing, when the frequency is higher, you can see very nice images, but only the depth is decreased. So you can see the superficial structures much better with the higher resolution with the high frequency probes. So these kind of probes, linear probes, are usually used for the vascular studies, for superficial structures, and for the lung if you are looking more on the pleural line, pleural, because it gives you much better look of the superficial structures. But the sector and the curved linear probes, they have a lower frequency, but their depth is more. So you can see more deeper structures, such as you can see the pelvic organs, you can see the abdominal organs. So these are the probes which also can be used in the lung, which are used in the lungs and in the abdominal and all the other bedside exams. Now, why I showed you two probes over here, curvilinear has a wider look because it has a wide footprint, so you can see much wider view. I will show you the slides in a while. And the sector probe, because you are looking through the intercostal spaces, so that's why this gives you a very ease when you are scanning through the intercostal. For example, you are looking for the lung and you are also looking for the heart, so it helps you in the view of through the intercostal spaces. But for the looking through the intercostal spaces by the help of the curvilinear probe, you just have to use you have to find the proper window so that you can see. So this one is commonly the probe which is used in the bedside exams commonly. Okay, I just talked about the indicator. So why the indicator information is very important that you should know about it, because this gives you the orientation of your image. So for example, this is the probe and here is the indicator. So always remember that the indicator direction should always be like this is the transverse view. So indicator should always be pointing towards you when you are scanning in a transverse plane. And when you are scanning in a longitudinal plane, so the pointer, this is called the pointer or the indicator or the notch, it should always be facing towards the patient head. Now this is important because of the anatomy on the image. And the another thing is important that on the screen, so this is the screen of the, or the monitor of the machine. So you will see this is the indicator, which should always be on the right side of the machine. So this is a little bit about the information about the machine, so that you can have a proper orientation of the images. Correct probe holding is also very important. You should have a tight grip of your probe, and plus it should be in contact with the patient's skin with the appropriate, with a copious amount of gel. Okay, so now we will come to the.
Sorry, Dr. Rozina, अभी भी थोड़ी सी problem है audio में, तो can you please check the audio settings? Sometimes got better, but sometimes not.
अभी आप देखें, is it better now?
I think it is better.
I don't know why.
प्रॉब्लम आती है कोई?
हाँ, बात आता I don't know, क्योंकि मैंने जब रिकॉर्डिंग अपनी प्रीवियस की भी सुनी थी, तो उसमें ठीक ठाक चलते चलते एकदम बीच में थोड़ी सी टर्बुलेंस आ गई थी. अभी ठीक है?
जी ठीक है, अभी कंटिन्यू प्लीज.
अच्छा, जिस वक्त भी कुछ प्रॉब्लम हो तो प्लीज मुझे बता दीजिएगा. अच्छा सर.
राइट, थैंक यू.
Okay, so now we will learn how to scan the lung. So इसके लिए सबसे पहले आप क्या करेंगे, lung के usually I adopt the method which is called the 12 examination zone method, which means that I divide each side into 6 zones. So for that, you just draw an imaginary line on the anterior axillary line, and then an imaginary line at the posterior axillary line. So anterior and posterior axillary lines will divide the whole area of the chest into each side, right side and left side, separately into 3 zones. One is the anterior, then is the lateral, which is under the armpit area, axillary area, and then the posterior side. Then draw another imaginary line, horizontal imaginary line. So this will divide your lung into 6 zones on each side. Now the anterior is over here, which starts from the left side of the sternum all the way to the anterior axillary line. And then you see this one is the upper lobes. So the horizontal line divides the lung into upper zones and the upper lung lobe and into the lower lung lobe. This is just for your orientation, that how you, when you are scanning, how you divide the chest area so that you can see evaluate the lung. Okay, so now we come to the scanning, that how we scan the lung. So always put your probe, start your exam by putting the probe in a longitudinal direction with a good contact with the patient skin, and start it from the, now everybody, it depends on the person's practice, whether they start from the posterior side or whether they start from the anterior side. But anyhow, when you start, for example, we started from the lateral side of the sternum, and then we move all the way towards the lateral side, and then we go down, and then we scan again to going towards the medial side. So this is how we scan the anterior part of the chest. Then we go to we ask the patient to raise their arm, and then we scan the lateral side using the same maneuver that we move towards the lateral side. I mean, we have to check both from the left to right, and then to the from down to the upward, all the way to the axilla. And this is over here. Then we, on the posterior side, we do the same technique. Sometimes, because when you go to the upper area, so the upper part is a little bit hard because the scapula is lying over here. So I always ask my patient to hold their hands like this, so that you get the scapula moves away from your from your view, so that you can see the underlying, the upper part of the lung from here. Another good tip is here, sometimes even if you cannot see the upper part of the posterior, upper lobe of the posterior lung from here, so I sometimes go under the axilla and try to see the upper posterior lobe from the axilla. So you just put the probe under the axilla and just try to move it so that you can see the upper part. Okay, so now we will go to the lung anatomy. I use the entire exam is done with the SONON. This is the handheld device which I use for the examination. So look at over here, the normal lung anatomy is very important for you to know that what you are looking at. So once you put your probe on the chest of the patient with using the enough gel, so you now look at over here, the marker is facing towards the patient head, and my probe is very perpendicular to the patient chest. So perpendicular to the chest, and you also have to look for anatomy like this. So now what is this? So when you put your probe on the patient chest, you will see the bright line, which is on the both sides, and then you will see a dark shadow behind these bright lines. So this bright structure, which is called an aquagenic structure, is the rib. The bones and all these structures, the bones and the stones, they look very bright, very hyper-echoic, and these are the calcium-containing structures. So the rib is over here, and it will give a very dark shadow. So we identify these two ribs and the dark shadows, and in between the two dark shadows, you will see a very thin line which will be moving. So this is your pleural line. So finding this landmark is very important for you. So when you put your probe on the patient chest, try to find out this anatomy. Now, in that case, you know, because your probe and the sound waves should also be perpendicular to the pleural line so that you can see this anatomy. So sometimes what happens, this is a technical tip. Sometimes when your probe is right straight on your on the chest wall, but you don't see this anatomy. So try to move it because your sound waves are now not striking the pleural line perpendicularly. So what you have to do, just slightly rock your probe, like move it like from side to side so that you can see the bright line on the side with the dark shadow and this white line. So once you find this anatomy, then you start scanning your image. So I already told you that this bright line, these are the two ribs, and in between these two ribs is giving the black shadow, and then in between is this structure, which is the pleural membrane with the pleura, and it is the interface of the visceral and parietal pleura. Now above that, you will see some grayish colored structures, and this is the intercostal muscles, and then you see the subcutaneous tissue, and then on the top is the skin. Now, if you look at over here, below this pleural line, the bright structure, below is all the lung. So this is all the lung, which you will see somewhat like a grayish structure, but you will not identify any proper thing that what it is over here. Now the artifacts we will talk in a few minutes, okay? So I'm sure that now you understand that what is the landmark which you have to look when you put your probe on the patient chest. Now over here, the lung ultrasound is mostly dependent on the presence of some artifacts. So the first artifact which you will look is the reverberation artifact, which means that the sound strikes, the sound wave, because ultrasound is a high frequency sound waves. So when the ultrasound beam strikes the pleural membrane, it is reflected back, and then it gives the artifacts posterior to the pleural line. So this type of horizontal lines, if you look at over here, the horizontal line, okay, if you look at over here, these dark shadows are the rib shadows, and in between is the lung tissue, and this white line is the pleural line. Now, if you look at over here, below this pleural line, you will see another equidistant white line, horizontal line, the one horizontal line over here. So these horizontal lines are called the A lines. Now the presence of A lines mean that it is a good aerated lung. So the presence of A line, which is an artifact, reverberation artifact, it gives you the information that this is a normal aerated lung. Now over here, I scanned this image with using the linear probe. If you look at over here, and this image is scanned with the curved probe. So if you look at over here, the difference between the image which is done with the linear probe and the one which is done with the curved probe. If you see on the curved probe, I have a wider look or wider appearance of the underlying structure. So we can see the rib, black shadow, rib, black shadow, and in between this is the pleural line, and then I see the equidistance A line. Now, some of the people, they call this type of structure, like the black structure, the rib, they call it as a bat sign also. Okay, so the A lines, it means the normal aerated lungs. Now, another artifact which we see is a vertical line starting from the pleura. This is a vertical straight line. These lines are called the B lines. So the first one, the horizontal line, is the A line, and then the B line, which is the vertical line, and it extends from the pleural line all the way to the bottom of the screen. So normally what happens that in one imaged area, like in between the two, or the one scanning area, for example, the area between the two ribs, if you see one B line or two B lines, or even in some cases three, but they are very thin and straight, so they are considered as the normal artifact. So look at over here, I showed you the A lines, which are the equidistant from
Sorry,
the...
Dr. Rozina, जरा थोड़ा सा ऑडियो चेक कीजिएगा, जरा थोड़ा सा प्रॉब्लम आ रही है उसमें। दरमियान में कुछ बेहतर हो जाती है, लेकिन ये कि पता नहीं है।
अभी अच्छा, अभी ठीक है, मैंने लो पे सबसे लो रख लिया है।
मेरे ख्याल में कुछ बेहतर है, वो अभी शायद फ्रीक्वेंसी का इशू आ जाता है। चलें, ठीक है, कंटिन्यू करें प्लीज।
हाँ जी, ओके, फिर मुझे बताते रहिएगा प्लीज।
चलें, कोई बात नहीं।
हाँ जी, क्योंकि ये इतना इम्पोर्टेंट है कि ये अंडरस्टैंड करना जरूरी है कि ये सही तरीके से जाए, ठीक है ना?
जी ठीक।
अभी सही है?
जी बेहतर है।
Okay, okay, so these horizontal lines, this is the horizontal line and this is the A line, and this is again the rib shadow. Okay, so let's, okay, sorry. Now this is the video clip. So if you look at over here, you see, this is the A line, this is the A line, this is the pleura, and this is the A line, and this is the A line. Now the question over here is that what are these? Also, the you see a lot of A line, you see a lot of horizontal lines. So
Dr.
which one
Munir,
is?
I'm sorry to interject you. Let me try. Let me ask you to try something. Are you able to just mute your desktop or laptop while you're doing the presentation? Because none of us is speaking anyway. That might allow us to hear you more clearly. And once you're done with your talk, then maybe you could unmute yourself. Try that, please. And also, this will be sort of a 5-minute heads up as well. We're we're at 8:25 right now. So go right ahead, please. No, don't mute yourself in Zoom. Just mute your desktop. Keep yourself unmuted here so we can hear you. So your microphone will remain unmuted, but your speaker will be muted. Thank you.
Oh, okay. Is it better now?
Yeah, it's great.
Hello? अभी सही है आपका? मैंने Hello?
Yes, that's fine now. Can you hear me?
हाँ जी, अभी आपको ठीक आ रही है मेरी आवाज?
जी ठीक आ रही है।
अच्छा, फिर मुझे बताइएगा, पता नहीं क्या मसला हो रहा है, समझ नहीं आ रही मुझे भी। अभी ठीक है ना?
जी ठीक है, please continue.
हाँ जी. Okay, so sometimes the question over here arises that you see a lot of in this image. This is the normal aerated lung, and you see this is the pleura. Okay, and then you see these number of lines, A lines over here, not the A lines, sorry, the horizontal lines over here. So now the question arises that, okay, which one is the A line? Because you see a lot of these horizontal lines. So the answer to this is that only those lines which are, if you look at over here, this is a horizontal line which is more regular, which is brighter, and it is continuous all the way, and plus it is equidistant from the pleura. So this is the A line, not this one. So this is A line, so this is another A line, and this is another A line. All these are just also the reverbation artifacts, but they are not complete. You see, they just fade away as they go towards the end. Okay. Now, this is the image which shows you the normal B lines. So you see, this is a normal, this is the pleural line, and from there you see a horizontal, the vertical, thin, regular. So it is not fading as it goes down. So this is the B line. And in one area of what you are scanning, if there are 1 to 2 lines or 3 lines, so they are okay, but they are not fading. So this is also called as the lung rockets. So this is the scanning with the curve probe, and you can see the A lines, the pleural, and then you will also see somewhere this one we just disappeared. So this is one, you saw one B line. So this is the normal lung scanning. The dark are the lip shadows. This is another image. You see this B line over here, and this is the pleural. And now over here, I just have seen I just brought the, zoomed the area of the pleural line because I want to see the sliding. Because the visceral and the visceral and parietal pleura, they slide each other, and this sign is called the sliding sign. And this is a very important sign because the presence of this sign means that there is no pneumothorax. So look at over here. So you see this one is the sliding sign. And if you look at over here in this video, you also see the sliding, but over here we have zoomed it and you see one B line also over here, and then the presence of the A lines. So this is a little bit more closer look of the pleura because I want to show you the sliding, normal sliding sign on the lung. So if you have seen that sometimes you will also see small little vertical lines, very small, which are not going all the way to the end. So these are called the comic tail. Actually, the B lines are also the comic tail artifacts, but the B lines are called B lines. Why? Because they go all the way to the bottom of the screen. But the comic tail artifacts, they just present only to a little bit of the distance. They don't go all the way to the end. So, मतलब ये हुआ कि comic tail B lines are the comic tail, but the comic tails are not the B lines. Okay, so then we also scan for the pleural effusion. We always scan for the so we scan it from the laterally. So you put your probe over here, and you will see some structure which is the liver and the kidney. And then below that, above that, you will see this bright structure. So by putting your probe on the end of on the lateral side, this is done when you are scanning for the fast exam to look for the free fluid. So you will see this bright structure, you will see the right kidney, and you will see the liver, and this area you see over here, above the diaphragm, the bright structure is the diaphragm, and above that is also the normal aerated lung area. So this is the most common area where you look for the pleural effusion. Similarly, on the left side, when you put probe over here with the indicator facing towards the patient head, so this is the left kidney, spleen, and then above the diaphragm is the lung area. So these are all the videos.
Thank you. I will give you a 2-minute heads up. Please carry on. Thank you.
Okay. It's fine, right?
Well, we are about approaching the halfway mark. So in order to take some of the questions as well, I'll just ask you if you could wrap up in 2 to 5 minutes, please.
Okay.
Thank you so much.
डॉक्टर रजीना, आई थिंक अगर आप राइट साइड पे होके थोड़ा सा फेस करके अगर स्पीक करती हैं ना, तो मेरा ख्याल में कुछ बेहतर ऑडियो आती है. थोड़ा अपनी राइट साइड पे अगर देखें, अपनी राइट साइड पे फेस करें. जी जी बिल्कुल इस तरह.
तो आवाज सही आती है?
जी इधर सही आती है, मैंने नोट किया है.
अच्छा. और टाइम कितना मेरे पास अगर है नहीं है?
जी आप कंटिन्यू करें.
आपके पास दो मिनट और हैं, अगर आप wrap up कर दीजिए. You've already gone through the lung ultrasound. That was excellent. So if need,
मैं कोविड पे फिर okay मैं कोविड पे चली जाती हूँ फिर अभी.
That would be great. Thank you so much.
Right, okay.
And you can always chime in more, during the question and answer session.
Right. Okay. Okay. So this is just scanning, how we scan. So I just show it to you that we start from the lateral side and then going all the way towards the lateral. And then I already explained it to you. So I'm not going through this slide. So let's go. I would like to go to the patterns of lung ultrasound in COVID-19. So this is something very important. So for the COVID-19, you have to look for 5 characteristic signs. So number one is that if you look at over here, this is the normal pleural line, and usually it is regular and thin, and the measurement is not, it is always less than 2 millimeters. But in case of COVID, so you will see the pleural line will be thickened, and there will be irregularity on the pleural line. So this is one of the signs which we, after collecting different data, we just came to know that the COVID-19 patients, there is a pleural line irregularity. Another important thing is over here. So if you see the B lines, so B lines will be not this is a normal B line in normal aerated lung, but look at over here in a patient who is suffering from any interstitial lung disease, not only the COVID, but in any interstitial disease, you will see the B lines, which is coming from the top, from the pleural line, but it is fading, and it is going like over here, like you see how it is fading, just like a torch light. And so this is the early stage, and then in the advanced fibrotic condition, you will see more confluence of these B lines. So this is the this goes with the as the disease progresses. Okay, over here, this is the normal lung, and look at lung sliding is still present, but look at over here. You cannot see any, you cannot identify any A lines, and look at the B lines. This is the coalescent B lines. Okay, so this is again the same slide, another slide. Okay, let's go. Okay, another thing, so I just say that the presence of, the third is the consolidation. So first problem was, the third is the sub-pleural consolidation. So if you look at over here, this is the normal line, but in case of the COVID-19 patient, you will also notice change, which is the irregularity in the pleural line. So this is called the consolidation. This is also present in the COVID-19 patients. This is the little bit more advanced stage of the consolidation, where the patient is now developing the lower pneumonia, and you will see somewhat like a structure which looks like more like a liver, or like an organ-like structure, and you will have a lot of echogenic lines inside it, or structures. So these are the air bronchograms. So more details we will learn in the MERIT COVID. MERIT APPNA Academy. So look at where this is the COVID-19 patient, and look at over here the irregularity and also the sub-pleural consolidation with the air bronchograms. This is another one example. Another feature with the COVID-19 patient is that you will see the skip lesions in between. So you will see normal lung, and then you will see the thickened or irregular pleura, or with the abnormal B lines. So you will have the skip lesions in those patients. Now, pleural effusion is very rare in the COVID-19 patients, but this is the image showing you that how fluid looks like. It looks more like a black. I'm not going into the detail of this one. Okay, the recovery phase is the one where, with the recovery phase, you will see the visibility of the A lines again in the recovery phase. So this is the A lines, and you will see it coming back in the normal line, in the recovery phase of the patient. Okay, so just in COVID-19 patients, you have to look for the pleural irregularities. You will have to see the confluent B lines. You have to see the skip lesions of the patchy distribution and sub-pleural consolidation. So these are the 3 things. These are the 4 or 5 things which you have to look for the patients who are suffering from the COVID-19. This is just a little diagram that shows you the distribution, and then it's self-explanatory. You can just read it later on. Okay, so this is a case of the COVID-19 patient, which we got it from the South Korea. So you see the B lines. You see how they look like a torch. So this is look at over here, this is the normal part of the lung, like a skip lesion is shown over here, and look at over here. So look at all these B lines, and look at the pleura also, it is also thickened. So these are the 2 cases. This is the case from the patient suffering from the COVID-19. So let's go to the Okay, so we are done with our talk, and there's also a little announcement that with special thanks to the CEO of Hilsilion of South Korea and the Vice President of Hilsilion, US and Canada, that they give a special prize to the members of the APPNA. This is the price for that. So if anybody is interested in buying the handheld device, they can just contact the Wali. So that's it, and thank you so much.
Great. Thank you very much, Dr. Munir, for an excellent talk and a very interesting topic. We have several questions coming through, the Q&A section here, the chat as well for the panelists who are unable to sort of access the Q&A to, ask their own questions. And then we have quite a few interesting questions related to COVID in general from the WhatsApp group as well. I want to the attendees to sort of know the full range of expertise we have available today among our panelists. Dr. Munir, of course, is a sonologist. I'm aware of Dr. Bushra, who is an expert infectious disease consultant at Aga Khan University in Karachi, and I'm familiar with Dr. Mariam Moten, who is an excellent cardiologist coming out of South Carolina. If the other panelists could briefly mention their expertise as well. Dr. Nighat, you could start. Thank you.
I'm Professor Nighat Mir Ahmed. I am chair of rheumatology at College of Physicians and Surgeons, Pakistan, and at National Hospital and Al-Madin Medical College. This is a very interesting situation for us, where rheumatology is, I think, all these storms and use of all these medications. So I'm very much interested in this, and I'm exceptional effort by APPNA. I really appreciate it, and I've learned a lot from it. Thank you so much.
Thank you, Dr. Faisal. If you could introduce yourself, please. Go ahead, you're unmuted, but we can't hear you yet. Looks like there's some issues. So Dr. Muhammad Salim, if you could please introduce yourself.
Dr. Muhammad Salim Khan, Chief Consultant Physician, Kotli, Azad, Jammu and Kashmir.
Great, thank you so much, and welcome all of you. I am also a pulmonary and critical care physician and intensivist in Boston in the US. So I can also help answer some questions if they're directed towards that specialty. So I'm going to start with a question for Dr. Bushra. One of our attendees has asked a question about convalescent plasma therapy. The concern is, would not this passive antibody transfusion delay the natural adaptive or innate immunologic response among these COVID patients? What are your thoughts about that?
Not much is known about the efficacy of convalescent plasma. I think it's one of the, most of the drugs which are being used at the moment, and most of the strategies are just trying something which might work. So nobody knows if the antibody has any neutralizing effect or not. At what stage of the disease would it be most effective? So convalescent plasma treatment has been started at NIBD in Karachi, and 2 of the patients at Aga Khan University have also received plasma, which was collected at.
Sorry, we lost you there.
The RT-PCR remains positive in one of the patients 1 week after receiving convalescent plasma, but patient selection is not very stringent. So it is mostly families are actually pressurizing physicians to get convalescent plasma treatment. So the criteria for selecting patient for convalescent plasma are laid out, but they're not being stringently followed, and it's basically being used on compassionate grounds. So no idea at the moment about the efficacy in our patients.
Great, thank you very much. I'm going to ask another question, and I'll get, once I get to other panelists, they can certainly chime in on the, previous questions as well. Dr. Bushra, another question that was asked of us was about the confusion surrounding quote unquote day one, right? When you're talking about the serological timeline, what constitutes day one in your mind of disease, given that, of course, a lot of these patients are, sometimes subclinical, sometimes they're asymptomatic through and through. So how do you sort of define the chronology when you're trying to do that, let's say when it comes to serological testing or any other aspect of management? Dr. Bushra, you're muted right now.
Okay, can you hear me now?
Now we can hear you.
Okay, so day one would be the day one the symptoms appear, because there is no way of knowing how long the patient has been infected in the pre-symptomatic phase of the disease. So for selecting a patient for any of the therapeutic interventions, day one for me would be the day the first symptoms appear.
Excellent, thank you. Dr. Munir, I will ask you, a couple of questions people have sort of pointed towards. If you could clarify for us, when exactly should we be using ultrasound when we also have other imaging modalities at our disposal in the context of COVID-19? When would you pick up the ultrasound probe as opposed to getting a chest X-ray, for example, or a CT scan?
Yeah, like for example, your initial CT or chest X-ray is done, and it is found that okay, the patient has the COVID-19, and now the patient is, for example, is intubated or ventilated, and it's and it's in the unit. So in that case, it's very hard for you to, you let your radiographer or the CT or the big machines to go into the COVID-19 patient room. So in that case, it is very easy for the physician who is taking care of that patient to just see and monitor the patient's the patient lung, and also to get the answers for any of the questions, for example, about the heart or for the other conditions, for example, for the CVP line or anything. So that's in that situation, the use of the use of ultrasound is very helpful. But for that, the physician must have the know-how, the physician must have the training in the point of care ultrasound. So usually it is after the initial CT or initial X-ray, you can just look for the progress or the prognosis of the patient.
Great, thank you very much. One of the attendees has also asked whether we are seeing increased blood clot formation among patients with COVID-19. I think by now we have a increasingly robust, sort of published literature on this issue as well. Certainly, this has been my observation and my colleagues' observation at my institution as well, where patients with COVID-19, at least, the subset who are sick enough to be admitted in the intensive care unit, tend to have, fairly high rates of clotting off either their central lines or their arterial line catheters or their hemodialysis machines. We're also seeing folks who are getting, cardiovascular accidents or strokes. There's also been good reports, as I'm sure Dr. Maria Moten could attest to, of people coming in with ACS, acute coronary syndromes, which are thrombotic events as well. So this is certainly something, and you'll find plenty of literature on this as well. These patients definitely do seem to have an increased propensity for blood clotting. Some within the institution, sort of research that we have carried out thus far suggests that most people who don't have illness that is profound enough to require intensive care they don't seem to have quite the same rates of blood clotting as those who are much sicker. This could just be sort of the sickness, the amount of viral load. Perhaps this is a reflection mostly of the intensity of and the magnitude of the systemic inflammatory response that those particular patients generate in response to this viral infection. Um, a related question is, what sort of thromboprophylaxis regimen should we follow? Should we should we do the usual amount of thromboprophylaxis? We at most institutions, mine included, tend to give all hospitalized patients subcutaneous heparin in one shape or form or another to prevent or mitigate the risks of DVTs and pulmonary embolism. Should we give a more aggressive thromboprophylaxis regimen for these patients, and how should we follow it? I think this is something that all of us are struggling with a little bit because there's not great data that sort of speaks to what would be the ideal sort of regimen. I just shared in the chat forum a link to something called covidprotocols.org, which is a list of publicly accessible COVID-related protocols continuously updated based on incoming literature that my institution has put together, but has made it available for free public use as well. And you'll see here, if you went into the hematology section, that we have, after much debate, deliberation, and review of literature in a truly interdisciplinary fashion, we have decided to up the amount of thromboprophylaxis for patients who are admitted in the ICU. So please do take a look at that. We try to stratify based on patient's disposition. Are they currently on the floor or in the ICU? Whether they're obese or not, and their sort of set criteria, what's their renal function, and so on. I will let any other interested panelists sort of chime in on that as well. And I'll also ask one question of Dr. Naheed, if you have seen any rheumatic changes or rheumatic manifestations yet among these patients. Go right ahead, Dr. Naheed.
Yes, this is very interesting because before I answer that question, can I say something? We have, this is just like the cytokine storm is behaving like mass in our settings, where there is macrophage activation syndrome. And we have like 2 people died of pneumonia who had lupus. And unfortunately, we do not have the details as yet because they were colleagues, and we are hopefully joining the Global Rheumatology Alliance on reporting these cases. But their swabs sent twice came back negative, and one of the BL Lavage, reports for also came back negative. So I personally haven't seen them, but there are some patients who have been coughing, having fever, rashes, and worsening, and we are very closely following them. And I know that they can come up, COVID-19 can just behave like involving every organ. Vasculitis is mimic for that. So we are keeping a watch out on that, and we'll definitely report on that. My question and a comment is that B-cell therapies, have they been looked into in any of these? Is anybody aware of that? Because there's a report that patients who had hypogammaglobulinemia and agammaglobulinemia, they had less severe disease, and they had a good prognosis, and they returned home. And whether B-cell targeted therapy would also be looked into some protocols.
I'm not aware of that. I know that people are certainly looking at intravenous immune globulin treatment, immune modulation through a whole host of agents. Dr. Bushra or others, are you familiar with any data? I haven't actually looked at that report of hypogammaglobulinemia patients having
That
less
was in
severe
the
disease.
Journal of Allergy and Immunology. That was in Hematology Morning Wire. And
Is that a case series?
yes,
I
it's
see.
okay. Yes.
Yeah, I wouldn't know what to make of that when we know
Yeah.
that the vast majority of patients will have less severe disease at baseline, including those with comorbidities. But it's an intriguing thought. Thank you. Thank
Can
you
I say
for sharing.
something? There's one more thing, because don't we agree on this, that there are phases of this infection. The first phase is the infective phase when the virus is replicating. And if we use whatever therapies, antiviral in that early stage, then maybe we are going to not let the patients progress into the second stage, which is like all immunology. That's got nothing to do with infection. That's all about the cytokine storm. So so what I see is different peoples are doing different protocols all over the world, all over the US. So is there any consensus on that at all, that if the first stage is the one where the virus is replicating, when there is an infection, and we can put all our effort, maybe HCQ, Zithromax, whatever it is. But once the cytokine storm starts, then, you have it's all immunology. And finally, when people go on vent, the mortality is so high. And I keep on thinking that we spend a lot of time, I know, on doing, saving those patients, which we should as physicians. But when times come and ventilators are not available, I think we should also focus on what can we do in the first and the second stage. And most of all, how do we prevent it from spreading, which we need an epidemiologist everywhere, I guess.
Excellent point there, right? I think that, as you said, it has nothing to do specifically with COVID. This, of course, is similar to the treatment approach that we adopt for patients who get influenza as well, right? If you have to give oseltamivir or any other virus-directed therapy, it is much more effective if you give it within 48 hours of the development of symptoms. The trouble right now, of course, with COVID is in the absence of data, we also don't have a very good, robust way of predicting who is going to develop complications. With influenza, we have a slightly better handle on that. So not everybody who gets the flu gets the oseltamivir, but rather those who are either sick enough to be hospitalized or otherwise have conditions that predispose them to complications are the ones that get it. Obviously, we're in the early phase of learning here, but you're right. I think sticking to time and tested principles and trying to avoid excessive speculation and excessive experimentation is usually what turns out to be the best approach. Fear drives desperation and then a lot of experimentation. And sometimes, as we've seen with, the Ebola and some of the other epidemics as well, that can lead to more harm than good. So thank you for that commentary. I have a question for the general sort of panelist audience, and anyone else among the attendees can also sort of chime in the chat form. One question posed to us, which I don't know the answer to, is whether Britain is starting any trials on humans with COVID-19 vaccination. Just a specific question, if anyone knows the answer to that.
It was on the TV. This
Yes.
is Mary Morton. It was on the TV recently indicating that 2 patients have been given vaccination for COVID-19 prevention.
Great. Thank you very much for sharing. There's a couple of questions that are sort of, speaking to the medium to long-term management of these patients who are sick enough to be on the mechanical ventilator. One attendee has asked, for those COVID-19 patients who need prolonged mechanical ventilation, what about tracheostomy in these folks? What are the benefits? What are the risks of tracheostomy? This has been a subject that we spoke about in great length in one of the earlier webinars, one of the earlier merit webinars, and I'm going to post a link to that YouTube video I just did. So please feel free to take a look at that as well. We address this point in sufficient detail, but it's a very good point. Of course, you know, with every passing day, we develop a greater understanding of this as any other aspects of the management. I'll just say, I think this will become more and more important, especially as the ICUs become fuller and there is need to have a basically a pop-off valve to really free up ICU beds, especially when and if, God forbid, a true surge does arrive in Pakistan. So excellent question there. We have a couple of folks who have raised their hands and would like to speak, so we're going to have them. I don't have sort of the name. Please go ahead, introduce yourself and ask your question.
I'm Dr. Shahid. I'm working as consultant neurologist in National Medical University Multan Hospital. And my question and my comment with the Madam Meet is that as neurologist, most of my patients are on the disease modifying drugs, like some autoimmune diseases, and they are on the disease modifying therapies. But what precautions as a physician we must take care and advise to the patient regards the disease modifying drugs? I need the comment and the suggestion of Madam Meet, because as a rheumatologist, they are she would be having more experience of using it. And next, I want to ask about the procedures of the convalescent plasma. If anybody of the panelists can share it with us, it would be also beneficial. That's all. Thank you.
Thank you, Dr. Nighat.
Thank you so much for asking that question, because this is a question asked by everyone. The ACR guidelines are that if patients are on DMRs and they are stable, we should not stop those at all. We should, if there is an infection of any kind, we know that we have to stop them. But otherwise, we should keep them continued. The only precaution I'm sending with my telemedicine consults to all patients is corona precautions are sent with every message to the patient that they have to be very careful and follow the guidelines for prevention. Second, patients who are on biologics and are doing well, we'll not stop their biologics. We'll continue them unless there's an infection. And third is, but patients who are on biologics and a DMR and have comorbid conditions like diabetes, hypertension, age greater than 65, they have to actually literally self-isolate them. So there are excellent ACR guidelines, which I can share later on the link, which guide us as to how we proceed with these patients. So I hope has that been clear to you and have answered your question?
Great, thank you very much. And Dr. Bushra, if you could share sort of the contours of how to administer convalescent plasma. Thank you.
I can send the link to the AKU protocol. I'm just looking for it. So there are two aspects to it. One is collection of convalescent plasma, and there are requirements, stringent requirements for the donors. And the second one is actual infusion of plasma to the patient. So there are two components to it. And I think I will send you link to our protocol after this.
Excellent, thank you very much. And Dr. Rozina, there's a couple of questions sort of directed towards you. If you could speak to how the ultrasound appearance in COVID-19 sort of differs from regular pulmonary edema due to other causes, or acute respiratory distress syndrome due to other causes.
Yeah, okay. In COVID-19, because it is the interstitial disease. Can you hear me properly?
Yes, please
okay,
go.
Maybe because, maybe I turned off my video. So, okay. So in pulmonary edema, what happens that it is because of the increase of the fluid. So in that case, you will see the B lines, but it will be more diffuse. But, if you look at the pleural line, that will be very thin. But in case of the COVID-19 patients, you will see the thickening and the irregularity of the pleural line. The rest of the B lines is obviously be over there. That's why at this part, when you see the like the B lines, and if it is hard for you to see the pleural line and you're not even sure that whether the B line, whether the pleural line is thickened and irregular, you can also have a quick look of the heart, and then an IVC. This will give you another idea about that, whether the B lines is due to pulmonary edema or it is because of the other condition, like a CCF.
Excellent. Thank you very much. We have another attendee who has raised their hand. Dr. Azim Imran, please go ahead and introduce yourself and ask a question.
Assalamu alaikum. I am the family physician in Faisalabad. I want to ask regarding the what is the gold standard investigation regarding the radiology. Either it is a X-ray or a CT chest, or is it this ultrasound lung? How you recommend the gold standard? I think the ground glass appearance on the CT is the standard screening investigation for the COVID-19, and for the serial management and the serial investigation is the ultrasound. What should we use it?
Dr. Rozina, would you agree with that?
Yes, I agree with this, because after the initial investigation, for example, a CT or X-ray or whatever investigation is done, because those are the gold standard, then for the serial or the follow-up exam, you can just have a look for the, you can use the ultrasound and use of ultrasound by the physician. So I agree with your comment.
Okay, great. Thank you very much. There's a question about can COVID-19 be transmitted by connected sewage lines, for example, from one apartment to another? Is there any truth to that? Would any panelist like to comment on that? Dr. Bushra, would you like to take that?
I think we addressed this yesterday. Theoretically, you are bound to find all sorts of pathogens in sewage lines, and there may be some aerosolization during the passage of sewage from one pipe to another. But would that lead to spread of infection? That's something to think about. It has never figured as a major way of transmission of disease. I think it was found with the earlier SARS outbreak as well. The virus was found in sewage pipes as well, and SARS-CoV-2 is also excreted in stool. So it is bound to be found in environment and in sewage, but is that important for disease transmission? Not really. Transmission is person to person at the moment.
Great.
Can I ask Dr. Bushra a question, Dr.
Please.
Dr. Bushra, because we know that it's, the reports that it's excreted in stools, and remember by how we care about, isolating patients who have typhoid and, making sure that, checking that out. So people who are going to be doing that, how are we going to make sure that how long these people, are to be screened for that they have cleared it? And, because that could be a great source of infection, because not through sewage lines, but through hands, and if the hand hygiene is not done properly.
So even at the moment, hand hygiene is being stressed upon. People have to keep their hands clean. That is mostly because they handle their nose and their mouth, and their hands may be contaminated with respiratory secretions. The problem is we do not have any methodology for testing stool for the virus. So at the moment, it is only the respiratory secretions which can be tested. So I asked our molecular biologist early on when this pandemic started, and she said we do not have a protocol for testing stool. So it's not available in the country. So when we don't know how long or how important is this shedding in the stool, we won't be able to implement any measures directed towards preventing that. But keeping the hands clean and the bathrooms clean is actually good enough.
Thank you.
Okay, great, thank you. Now here's a question that I would pose to any and all of our panelists who are currently based in Pakistan. And the question goes, I quote, we have scarce resource committee that evaluates the resources for COVID-19 pandemic on a weekly basis and evaluates the availability and use of PPE, ventilators, beds, and then the triage of patients to COVID negative and positive sort of floors. Is there a similar practice in Pakistan? Essentially, continuing to look at supply versus demand.
Can I say some? I think we are like like 200 million people here, and our public hospitals are packed, and with the restrictions easing on and everybody coming in contact with each other. I think that keeping up with the people, this PPE supplies, the mask is going to be a really challenge here, and I think it's not possible for the government to supply at that rate, because just like we heard that there are going to be deliveries and the corona wards, and I think the supply and demand is going to be way unbalanced, and that's how I feel, because who is going to monitor this? I think the public hospitals, the CEOs of all the hospitals, I think they have to be on top of every, and they are, most of them are, but still we have complaints coming in that people don't have masks and they don't have PPEs.
Great, thank you. Dr. Bushra, is there anything you would like to add to that?
Yes, so I think the private institutions have a system of supply and demand monitoring. And the Expo Center in Karachi, which is serving as the isolation center, which has a 1,200 bed capacity at the moment. There are less than 300 patients over there. They have a very good system. They have established all the systems in place, whereby they're monitoring the supply and demand and the human resource and everything. And I believe there are other centers which are operating on a similar principle. So the situation is not as grim as Dr. Nighat would assume. So there are centers, even the non-private ones, which are operating quite efficiently.
I agree with you, Dr. Bushra. Yes, the private hospitals, obviously, that should be okay. And there are centers dedicated here also, like PKLI, and there's an Expo Center also. But we all know that big public sector hospitals, at least in Lahore and other cities, are really overwhelmed with patients as well. So that is a great challenge. And although the government is doing its best, but my request to the ID team would be that I think the sooner we designate corona hospitals which are dedicated to just corona, the better it would be, because that way we won't infect our healthcare workers. I'm not talking about doctors only who are at the front line, but I'm talking about nurses, the paramedics, everybody. How can we control the situation in very busy public sector hospitals?
Well, thank you very much. We are coming to the end of another highly fruitful webinar. And we always will be back, and there will always be more questions to talk about. Our hope here is that people who are on the front lines in Pakistan can take some of the thoughts that were sort of shared over here, some experiences, as Pakistan is slightly farther behind, thankfully, on the curve right now. We hope to sort of generate these discussions on a regular basis. If you can, please continue to join us, and you can also look at the YouTube channel of APPNA MERIT, where you can find recordings of all of the past 25 or so webinars with a specific focus on one of the many topics every day. Thank you very much, everyone, for joining, and Allah Hafiz.
Thank you.
Thank you. Allah Hafiz.